Thank you, Debbie, and I'd like to thank everyone who is listening live or those who are going to listen to this at some other point in time. I told our group this morning that I was presenting on their behalf, and I emphasize that I'm in a great position because I get to share the work that really a large group of people in our health system have been doing for really almost 10 years now. I'm just going to share my disclosures. I'm an Amgen Speaker Bureau member, and I've worked, and I'm currently working on a med mining project with Amgen. So I have 4 objectives today. Importantly, we want to acknowledge the importance of any FLS database in program tracking, workflow, performance improvement. I told Debbie right before we started today that really every program is important, every program's data is important, and I think to move this field, we need to have more programs sending publications and reports, hopefully for publication in peer-reviewed journals, because it's going to move us. We'll apply how we at Geisinger use a very simple, inexpensive database really to track, measure, share data, find and address care gaps, and really try to improve. We're going to talk about FLS performance and quality measures, and really talk a little bit about what other database options exist. So this is a very typical patient that I might see this afternoon. This is a patient that was seen early in the start of our program, an 82-year-old woman admitted to one of our hospitalist services after a fall. She sustained a left femoral neck fracture. She had a history of severe arthritis limiting her usual activities of daily living. She was taking a calcium and vitamin D supplement, had no prior fracture, really had no terrible aggravating factors, was a non-smoker, never had taken glucocorticoids, but had never had a past DEXA or bone health prescription. In our program, an auto consult is placed. It comes to our department, and we go into the hospital to see the patient and to address post-fracture care. You can see a typical femoral neck fracture. We really get bare bones data in the hospital. We will get a calcium, a creatinine, a 25-hydroxy vitamin D level. If we think there's something else that we should do, we'll do it, but it's pretty simple stuff. The patient had a left hemiarthroplasty, was discharged on over-the-counter vitamin D, and discharged to a local nursing home for rehab. So our process begins when we see a hospitalized patient with fracture, and when we began in 2008, we were really working at 3 hospitals, but now we've cut that to our 2 major hospitals, that being Geisinger Medical Center Danville, where I work, and Geisinger Wyoming Valley in Wilkes-Barre, about an hour and 15 minutes away. We used to have an inpatient arm at a community hospital in State College, but a number of factors, really predominantly low volumes, prompted our group there to stop going into the hospital. Once any of us see a consult, a documentation is placed in our electronic record, and that is sent to what we call our data coordinator, who was hired about 9 months into the inception of our program. It took us 9 months to realize we at least need someone to help facilitate care, track data, etc. This is a very simple, this is what Karen sees when she gets that telephone encounter and puts the patient into a database. And additionally, behind the scenes, there's a very large expanding database that we continue to track as well. We try uniformly to place this, and really Karen in Danville really tries to facilitate care for our group in Wilkes-Barre and our group in the State College in Lewistown area. And she extracts simple data from the consultation and starts to put it into this Microsoft Access database, which subsequently reminds her to arrange future care. Again, this is a relatively simple thing, and we really made this decision primarily because of cost. It wasn't a major investment. And again, I showed this to our fellows this morning, and they said, boy, that does not look like an impressive database. And that's good, because everything that we have reported really comes from this. And we'll talk more about options and things like that. So what we try to do is schedule a post-hospital discharge visit, and that depends on really what happens to the patient post-discharge. That patient may go home. That patient may go to rehab for a short time. That patient may go to a nursing home for a longer period of time. So initially we thought we would see patients 4 to 6 weeks post-hospital discharge, but really from a practical standpoint, it's about 8 to 10 weeks that we typically see a patient for their first visit. Having said that, they're routinely seen in orthopedics in between, which just I'll come back to later, because we sometimes never see a patient who's seen in orthopedics and they never get to us. We'll talk more about that. We try to find where they are and schedule an appointment. If it's clear that a patient refuses to follow with us, and soberingly, about half of the time that's the case, we send at least a letter and a copy of our consultation to the primary care physician. Now, in our system, we are connected to many Geisinger-employed primary care physicians, and we additionally can communicate via our electronic record. But about half of the patients who don't see us, who are seen in primary care, see their primary care physician outside of our system, and about half are seen inside of our system. And we're working to try to make that better. And again, these are just data sheets, and Karen just adds to this as we get more information over time on these patients. So the post-hospital discharge visit, we obviously try to document accurately, carefully, and come up with a plan of care. Now, how we do this is a little bit different in Danville versus in Wilkes-Barre versus in our group in Lewistown and State College. Here, we've had 2 advanced practice nurses. Now 1, we've lost 1 to retirement, so we focus our care with her around these patients. Our docs in other parts of our system do it a little bit differently. We obviously try to get patients on medicine who are at high risk for future fracture and to follow them longitudinally. We have shown that we've been able to increase a baseline vitamin D level about 6 to 7 units very consistently throughout the tenure of our program. Obviously, we document fracture location and risk. When it comes to risk, obviously a clinical hip fracture is a high-risk patient. We are an all-fracture FLS. We did not intend to be an all-fracture FLS. That happened because our hospitalists and particularly our orthopedic colleagues just began sending us really every fracture in patients over the age of 50. So sometimes, depending on the fracture location and whether the patient's ever had a DEXA, we might need a DEXA to really know what that patient's risk is. And again, another simple data sheet. Again, we began in 2008. 9 months into the program, we got a data coordinator. We're a little bit different. Many coordinators are either nurse practitioners, registered nurses, physician assistants, and really what Karen does is kind of arranges the care and mans the data and does other facilitatory functions. And again, as I tried to explain, we're a little bit different in how we do it here and our other 2 sites. We try to see these patients yearly. For patients prescribed an oral bisphosphonate or raloxifene, we do try to give them a 3-month adherence phone call. we at least assess vitamin D at 6 months, and then based on clinical needs thereafter. And again, we try to see patients longitudinally, especially in the context of the question of how long to treat a given patient post-fracture. And again, a simple data sheet at 6 months. Now, we use the term outpatient hierarchy. Even before we started this program, we knew, and this was around 2007, we knew there was a drug, IV abandronate. We knew that IV zoledronic acid was likely coming to market in 2008 or 2009. And we knew even before then that some of our primary care doctors wanted help with some of their osteoporosis patients. So we developed this because ultimately when we started the post-fracture FLS, we were going to need to put them into this pathway. So it gave us a little time to work on functionality of how we do clinical care in our sites. And then post-discharge after a fracture, the patients just get scheduled into this pathway. So we'll go back to our case. We want to arrange follow-up once the patient completes rehab. We talked about communication to our data coordinator, but this case exemplifies the utility of fracture liaison services with case finding. The highest risk patient rises to the top with a sentinel fracture, and our efforts are designed to prevent further fractures. Other FLS programs may not have an inpatient arm. It's not necessary. Programs may utilize case finding via orthopedic alliances. Many programs are designed around the own the bone perspective. Smaller programs in communities rely on discharge coding, etc., and then outpatient care is arranged. Again, many programs may be hip only. We started hip only and really evolved just because our key stakeholders just began sending us all fractures. Now, this is just a overall summary of our program. Again, case finding. We go in and we develop a plan. It's very important because here in Danville, because we're working with advanced practice nurses, that plan is really part of our collaboration, and it starts the process. So it's really important to us to be as accurate and communicate efficiently. We have the database. It starts, and then we try to follow that patient longitudinally, and hopefully we don't lose patients to follow-up. So a database really should help any fracture program measure what they do. Because we have a task management program, it helps us coordinate care. And again, our data coordinator really facilitates care throughout our healthcare system with our two other groups. We can capture what we're doing and track. And what anyone does is specific to what they can do and what they believe in. And I'll try to share what and why we do what we do and why we believe in what we do. It helps assure longitudinal follow-up, but probably the most sobering measurement that we initially found was that so many patients, even after being seen, did not want to follow with a specialty program. They wanted to go back to their primary care physician. And I think a database helps us share what we do. I think publishing in this field is very, very important, and really sharing best practices, just like the wonderful resources on the NBHA website, and improve our performance and really improve our patients' outcomes. So again, we use a Microsoft Access database. I pretty much showed you the forms. If you look at this, it's really simple. And in my travels and discussions at ISO meetings, at ISCD meetings, other meetings, I've always felt that a database is a potential barrier to an FLS program even starting. Trust me, any program can start with a simple things, even something as simple as an Excel spreadsheet, which really we utilize when we retrospectively go in and review into the chart. We have to go into the chart for certain aspects of variables and outcome. And we decided at 3 months to at least call patients, and clearly we're not at all surprised when patients are having either trouble remembering how to take the medicine or issues, and then we determine whether an alternate treatment and an alternate mode of administering the treatment is indicated. So the data elements that we use, and probably most everyone uses, is fracture location, fracture risk, and again, fracture risk for clinical hip fractures is not a big, it's obvious, but for other fractures, we need some other data. Discharge disposition, where did they go? We decided programmatically just to determine what's mortality at 6 months post-fracture, and we've been doing that consistently. We know that about half of our patients that we see simply will not follow us. Many are followed in our system, but many are also followed in primary care outside of our health system, and we're not connected with the same electronic record, which is frustrating, and it really prevents us from trying to analyze this in an easy and effective manner. We assess vitamin D. We talked about the adherence phone call at 3 months. Monthly reports, what I would say, there are simple things that you'll find out that you can improve, and I will use the term safety net. The Kaiser system, with a incredibly elegant, super information system and registry, has empowered many people to identify safety nets or gaps at points in time, and have given them, empowered them to try to solve them. Our database does not have that functionality, but we've kind of learned where our problems lie, and we've made some efforts, and I'll try to share with those with you later. And sometimes the database is limited by staffing, manpower, what your registry can or can't do, and cost. So when I talk about risk, we focus on 5 patient groups: someone with a clinical hip fracture, someone who's had a moderate or severe vertebral compression on X-ray or a clinical vertebral fracture. The second group is the patient who meets a T-score osteoporosis threshold. It's a postmenopausal woman or man over 50 with a T-score minus 2.5 or worse. The third group is the patient that meets a threshold by the USA FRAX treatment threshold, a major osteoporosis risk of greater than 20% or hip fracture risk greater than 3%. The glucocorticoid patients, the ACR has a very complicated, updated 2017 guideline. We follow that. And then finally, Dr. Ethel Cyrus and her work group came up with an expanded clinical definition of osteoporosis: patients with low bone mass, particularly postmenopausal women who've had a distal forearm fracture, or postmenopausal women or older men who've had proximal humerus fracture or pelvic fracture and low bone mass, satisfy and are candidates for treatment. Now, our simple database allowed us to publish our 2008 to 2011 experience in Osteoporosis International, and really everything that we have reported and will continue to report really focuses on seizing some of the things our database can give us, coupled with some laborious spreadsheet-driven chart review. I'm going to share that and show that with you today. So in our initial publication, we described a random sample of what we saw on the outpatient side. I'm really going to focus today on the inpatient side. So in between 2008 and 2011, we saw that 15% of our patients were dead by the 6-month post-fracture time period. Not surprisingly, only 24% of patients were discharged to home. Most were discharged to either nursing home or rehab. In the first analysis, 52% of the patients in total followed with us in our outpatient pathway. Most importantly, and I think the thing that drives the importance of FLS is we treated 80% of the patients who agreed to follow with us who had no contraindication and were drug eligible, contrasted with our primary care docs in our system, very good docs, who treated patients 32% of the time. Now, I'll remind you that the reason FLS is necessary is because of this large gap that we've known for the last 10 to 20 years, where we estimate that only about 20% of patients after a hip fracture or other fracture have some type of medical evaluation and or are placed on any drug to reduce future fracture. We increased vitamin D by 6 units from baseline mean level to follow-up level. So this was encouraging to us, and we just kind of continued doing what we were doing, and again, I'll show subsequent analyses. In our initial analysis, we did have a little support, but we also had some cost for a data analyst and statistician. After this, every analysis we've done has come from our database and has required us to go into the chart, and we use a very simple Excel spreadsheet. I've become extremely facile at doing this with our fellows and other team members. The first thing we did after that initial publication was we said, we're seeing a significant number of men. So let's analyze them. So we looked at the first 500 men seen in our program. That was from program inception to about January of 2015. We've just had another publication. We don't have it in print yet, but it's been accepted to Osteoporosis International, looking at our 2013, 2014, and 2015 performance measurements. We've looked at our outpatient separate program again, and we just completed a 2016 analysis and are starting looking at what we did in 2017. So how do we do this? Our database can give us our patients. So for the analysis of the men and for the 2013, 14, and 15 analysis, I sent Karen a message and I said, Karen, can you give me the patients from 2013 through 15? She can do that. Some of the variables that we want to know, like age, sex, fracture location, where they followed up with us, where they followed in primary care, we can get. But to really determine today, were these patients treated and are they followed up continually, we still need to go in the chart. So again, to contrast with probably the most elegant system, which is that of Kaiser's, and I think most of us are in between there, they can do things that many of us can't. But that's all right. So even with this simple database, we've really been able to share our data, which is this is what we do. It's not perfect. We're trying to be better. But I think all programs, there are just many, many commonalities, the same gaps, and I think we can learn from each other. Now, this is what a typical spreadsheet looks like, and I've just expanded on what our disposition and fracture risk is. So I have a record number, a name, a consult date. Final disposition, we know they were either seen in High Rock, they're followed by one of our primary care docs, they've decided to be followed by their primary who's out of our system, they are deceased, or we subsequently learn that they're deceased when we try to enter the record. And then there's an other category. Fracture risk, we want to identify in those patients followed in our system whether the primary care treatment gap is better or worse. So we always look at that. We look at drug. We have decided, because Geisinger Health Plan is an allied partner with us, about 35% of our fractured patients have Geisinger Health Plan insurance, and they're very interested in patients post-fracture getting on drugs. So they're helping us, and I'll share what we're trying to do in our primary care network with them. We look at early and later deaths and whether we've lost the patient to follow up. And we really want to know, is the patient at high-risk drug indicated? If there's a contraindication, we're not going to hold anyone accountable to someone who can't be on a drug. At times we don't know their risk because they weren't followed up and they needed a DEXA and we don't have it. And this is just a copy of the notes at the end of the spreadsheet, and it's really stuff that it is not really high-powered statistical data, but to me, if we're treating or not treating patients we've identified post-fracture who are eligible, that's probably the highest performance measure, in my view, in FLS care. Now, in mid-2016, we met a data analyst from our medicine institute who uses a program called CEDIS, and we were able to program this, and this individual can capture and follow whether someone was seen in post-fracture consultation. They can track whether they were seen in orthopedics. We can track whether they actually did have a post-discharge visit with us. Did they have a DEXA? And over time, we are able to determine with this methodology whether a patient was given a prescription or in-office administered treatment. So this is probably going to replace, hopefully, what we've done by hand, if you will. Now, what I'm going to do, or what one of our fellows and I are going to, we're going to look to compare what this method shows versus the usual method, and if there's, if essentially the results are similar, it's going to give us a quicker way to do an annual audit. I like the word annual audit because in the United Kingdom that's done every year. There are over 160 FLS programs in the United Kingdom, and you see what you're doing. Are you doing the same? Are you doing better? I think that's really, really important. By April of this year, that will allow enough follow-up from the end of 2017 really to complete this and see what our data shows compared to what we've reported to this point. So why should we do this? This is relatively, I would say, simple analysis, but it's critical because FLS goes in post-fracture to evaluate and to treat as indicated and to follow. What our data very consistently show is that an FLS program gets more people treated than primary care. It doesn't necessarily prove that we're better physicians. It's just the pathway and the resources and the ability to just focus on the bone problem that allows us to do this. And it also allows us to make a case in our system, particularly with our allied Geisinger Health Plan leaders, to work on making things better in primary care with their help. So I think we all need to do this in our own way. I think healthcare policymakers, insurers, managed care organizations, and the medical community at large need to know this. Now, last year, we're still aware of this crisis in osteoporosis care. I think it's critical to move patients to be more accepting of our really very effective therapies. Without knowing what you're doing, you really cannot improve. It's my hope that if programs are doing this, if this really matters to policymakers, insurers, managed care organizations, and the medical community at large, and it should, that then true pay-for-performance will be enacted. So I'm just, in the next couple slides, just going to summarize what I'm going to show you to be rather consistent data. In the first 500 men seen in our program, men accounted for 25% of the entire fractured population. Their 6-month mortality was 20% compared to 15% in our overall population. We treated 67% of the men who were high risk who followed in our High Rock outpatient pathway, but only 44% of the men followed with us. More men opted to follow with their primary care, but very, very worrisome and very significantly and this is a very simple analysis. I simply know that these men died. I don't know why. But from 2008 to 2015 in January, when our data was cut, we lost an additional 20% of the population. So at the time, 41% of this original 500 male post-fracture cohort deceased. Again, consistent with the fact that men have increased morbidity and mortality post-fracture. We don't know why, but we have to focus on trying to make this better. Our 2013 to 2015 analysis again showed 26% men in the population, mean age 78. About 2 out of 3 fractures were clinical hip fractures. 6-month mortality, overall population 16%, very consistent with the 15% we reported initially. And again, from the standpoint of treating the high-risk drug-eligible patient, we treated 75% in High Rock. Our treatment in primary care has really reduced to 14%. And I'm going to talk about how we're going to address that. We look to see how much of this population was Geiser Health Plan. In this analysis, it was 36% of all the patients. And we treated in High Rock 75% of those patients. The Geisinger primary care physicians did a little bit better, 20% in that population. Our 2016 data, again, 31% men, 17% 6-month mortality overall. Consistent treatment rate, 79%. Our primary care treatment rate, 17%. Again, I have no way to easily determine what happened to the other patients followed in primary care outside of our system, but quite honestly, my presumption is I don't think it's much different, but I don't know, and it would be very difficult for me to even try to begin to analyze that because it's so difficult. So we want to narrow our own primary care treatment gap. We looked at this data, and we were moved by it, and we presented this to primary care leadership, to leaders in Geisinger Health Plan, and we decided to form a work group and see what we could come up with. So what we're doing, and we have just started to do this in the last 2 or 3 weeks, when our data coordinator trying to facilitate post-discharge care learns that a patient is not going to follow in High Rock and has either GHP insurance or is followed by a primary in our system, we send a communication to a team of people, and what we're going to be doing is arrange a consultation in several primary care offices in our system with clinical pharmacists, and they're going to try to better educate and at least get patients on an oral bisphosphonate if that seems to make sense. We clearly anticipate that many patients seen by our pharmacists might need something else, but up to this point in time, if they won't see us, it's very hard for us to avail those therapies. And in our usual primary care offices, that is very difficult for primary care physicians to do themselves. Over this time, we've identified a number of barriers. Now, patient identification in our system's not a barrier because of the fact that this has been so ingrained in our system. Our orthopedists and hospitalists have really been extremely good partners. Any system or any processes can have communication issues, but we have an electronic record. We still have some trouble, but not too much. DEX is an issue only for those patients who need it because of a different kind of fracture and not enough data to know whether or not they're high risk. Everyone misses appointments. The lack of consensus amongst team members has been balanced by Dr. Adler's 2016 JBMR publication on long-term bisphosphonate therapy. And it's also been addressed by, we've kind of challenged our team to think of treat to target, a new concept championed by Dr. Felicia Kosman, Dr. Michael Lewicki, Dr. Stephen Cummings, and others. Our database issues are really not paying enough attention to what we can do with our database. I think in retrospect, we've fussed a little bit about what our database can't do and not seized enough, but I think we've kind of gotten over that. We obviously know that there's a significant mortality in this population. Probably the biggest barrier is patient engagement. Every system or every office has scheduling issues. These patients have transportation and family issues. We have to deal with long-term care facilities, and surprisingly, loss to follow-up. What I did not mention, in our 2013 to 15 publication or report, about 1 out of 3 patients that actually see us in the office outpatient-wise after inpatient consult, we lose them for some reason. We have to work to try to make that not happen. To me, the 4 main barriers are in patient engagement, fear of medicines, access to and affordability of the parenteral medications and anabolics, and frankly, losing patients to follow-up. Now, other databases and registries, I know a lot of programs that have started with simple spreadsheet. I think you got to start somewhere. Trust me, we use the spreadsheet. I import hundreds of patients over periods of time, and we put them into a spreadsheet. We analyze certain characteristics. We have certain things we already know from our database, and we try to see, are we doing better? Are we seeing any change, etc. The Own the Bone registry is very useful, and I would encourage you to go to the Own the Bone site, look at their registry, and look at their publications on what their registry has been able to show in a large cohort of patients. The NBHA, with funding from Merck and CE City cloud-based registry, showed that at MedStar Georgetown with Dr. Singer, at the University of Pittsburgh with Dr. Greenspan, and at Creighton with Dr. Reckner, that a registry can help you measure better and report and get more of the right things done. I think the issue with this registry is probably cost. And again, we alluded to Kaiser's very elegant system. Kaiser is a single payer system with a very elegant system that allows many people to have access and to fix problems as they're happening. Most of the problems we find are retrospective, and we're reacting to things a year or two behind and trying to make it better. And all of these things are an investment and cost, manpower, staffing factor into what a program does or doesn't do. Now, finally, I'm just going to talk about performance. I'm a relatively simple person, and I think, as I've already said, I think the highest bar measurement is post-fracture identification and risk stratification. What percent of drug-eligible high-risk patients are treated? I think we should also be able to show that our patients comply and adhere. What's really, really hard with FLS is to show, and we'd like to show it now, that we clearly reduce fracture. Methodologically, epidemiologically, statistically, that kind of stuff I really need help with, and we've not been able to really show that yet. that would be a very difficult thing, but I think over time we're going to have to do that. Again, the FLS is a coordinated, individualized pathway to medically evaluate a post-fracture patient, whether in the hospital or in the outpatient setting. So finally, I'm just going to conclude by saying you have to measure. To improve, you have to measure and compare measurements. We already know there's a wide post-fracture treatment gap. We know the significance of the morbidity and mortality of osteoporosis, the effect on quality of life, activities, daily living, effect on the family. FLS is necessary. Any FLS needs to be who they can be. We're going to be different based on who we are, where we practice, what our resources are. But I think we share the same fundamental approach and really what we're trying to do. In my view, an ideal database would be inexpensive, would be very low maintenance, would be something all of us in the field would agree pertaining to what are the key base measures, metrics, and accountability in regard to performance measures. And I think no matter what we use, we will find gaps, and we'll do something to try to see if we can make these gaps more narrow. So in conclusion, my children to the left, last weekend my kids became 25. I have identical twin boys. I'm older now, 25 years. They love to run. Steve Prefontaine is one of their running idols, and they always push me to not sacrifice. So what I'm saying is the FLS movement and any FLS program is really a gift to any medical community. So we all have to give our best. If we don't give our best, we're sacrificing what we have available to make our patients' lives better. So I thank you for listening and giving me this opportunity, and I'd be happy to answer any questions.
Wonderful, Tom. Thank you so much. That was an absolutely fabulous presentation, and we have several questions, so we will start in with those. I just wanted to remind everyone, please type your questions into the GoToWebinar panel, and we will hopefully have time to share them with Tom. So the first question we have is someone who is just starting from scratch in terms of implementation of an FLS. Is there a template that they can use?
So I guess the question would be a template as far as the typical metrics that that won't use. I mean, I think the answer is yes. I think you should start with something relatively simple. Honestly, if you track, now in no way do I think that what we track is the only thing you should track, but to me, what we really want to know when we see someone post-fracture is, again, somebody has a clinical hip fracture. That is the worst of the worst. They need to be treated. Excuse me. For other fractures, we have to look at either past DEXA and other risks with or without fracs. But I think, Debbie, you and I have talked over the last 2 years about the importance of can we in America agree on what a base database and registry should be, and can we agree on what we should track? Basically, what I've told you are the things that I so passionately believe in, and honestly, every analysis ends up on an Excel spreadsheet. So I think you can use an Excel spreadsheet. It's not something that I would want anyone to use if they had other options, but I would answer it that way.
Thank you. The next question is, in retrospect, are there any data elements that you would have added to your initial database?
Well, so that's easy. The answer is no, because what I didn't show you, and I can't show you because it's so huge, we have so much information on this big screen that goes left and right, in addition to all of those pages that or those sheets that our data coordinator uses. But the one thing probably we never from the beginning seized on Geisinger Health Plan. I just said, we were thinking of, is there anything else to do in 2013, 14, and 15? I said, well, goodness, let's see how many Geisinger Health Plan patients, we follow in the hospital and out. because, I mean, really, I would want to make the case to any invested payer in any medical community that this makes sense and try to gain their support. But I've had the opportunity to look at Kaiser's database, which, you know, is just so beautiful. But I mean, you need people to man something that's sophisticated. If I could have had anything from the get-go, it would have been maybe some investment from our system for some help behind the scenes when we want to do these analyses, because it really requires a lot of time. But that's, I mean, again, when it comes to data, I'm really pretty simple-minded. And again, that's how I answer that. Thank you for that question.
Great, thank you. The next question is, we have Epic, and is there anything you can share as we begin our program in terms of codes or order sets that we should focus on?
Okay, thank you for that question. So I don't know if this is true, but I've heard it. So I have not seen Rick Dell from Kaiser in a number of years. Rick has a mind. Rick is brilliant when it comes to data and orthopedics and passion and championing. So I have heard that he was able to do something with Epic. We do not use the full functionality of Epic. In fact, our database is removed from Epic. We extract from Epic. So to me, I think the key is what can Epic track and follow longitudinally, and the answer to that is your Epic IT people. What I'll tell you in my experience with IT in our system is this program, I'd like to have a hierarch icon that I could follow in Epic. I can't get that because there are just so many issues and things that are so much more important, I am told, than that. So if I had a hierarch icon or something that we could use to be so specific for our program, it would be beautiful, but we've not been able to accomplish that.
Great, thank you. All right, our next question says that you mentioned about patient identification, specifically orthopedics. Can you talk a little bit about coordination with the emergency department, interventional radiology, or neurosurgery?
Yeah, so very, very good question. So I'm gonna throw a shout out. When it comes to neurosurgery, I would talk to Avery Jackson and Kara Brock in Michigan. They have an ongoing FLS up there, and they can answer to that. I can tell you how we interact here. The ER is very good, and we can communicate, but much of that goes to ortho, and ortho knows who we are, and they get those patients to us. Perhaps maybe wrist fractures and other fractures that don't need to come in the hospital, we might miss in a way, and they're probably not the highest priority fracture in our system. Interventional radiology, neurosurgery, and orthopedic spine, they know they will consult us as well from the interventional suite if they do a kyphoplasty. So I think wherever you are, these are other areas that can allow you to build a program, get to other groups of patients that help you expand your FLS program.
Great. So our next question is, you mentioned the fear patients have of treatment and the issues around adherence. Have you partnered or worked with pharmacy or pharmacists on this end, or how have you handled the risk and benefit discussion with your patients?
So if anyone's gone to ISO over the last several years, Dr. Singer has brought in her patients to kind of help us learn what it is about their fears and expectations and worries. Dr. Lewicki has helped in that regard. I mean, that's why there's a crisis. For whatever reason, one of my associates this morning asked me, Tom, why is it easier to get a patient on an anti-TNF or a B-cell depleting drug or a drug that clearly has more risks than typical osteoporosis medicine? I think the way that the ONJ issue and the AFF issue came to be in the media, more so than us driving that, and that's influenced. But I mean, goodness gracious, our patients are just too fearful, I believe, of these medicines. Now, I mentioned Dr. Adler's paper. In that paper, there's a chart that shows that it's extremely more risky, or the risk of a motor vehicle accident or some other things compared to these very unusual side effects. Kaiser has used learning tools, and they're on the NBHA website. I think you just have to read your patient and kind of determine what they need, and every patient needs something different. But none of us, and no matter how hard we've tried, have been able to get, we don't have a spokesperson per se that we can go to and say, this person can really champion this cause. None of us in our own ways have been able to answer this to any patient's satisfaction. And it's very frustrating. I just think you just have to continue to try, and we have to learn from each other. Maybe psychologists can help us. One of the things that we probably could try to understand better with the volume of fractured patients we see is why they feel about the medicines, and what could we learn from that. That's just not anything we've really tried to do. So long-winded answer, but it's everyone's probably biggest frustration in the field.
Thank you. We have time for one last question. The question is, you mentioned one of the big barriers is lost patients in terms of patient follow-up. Can you share any of the insights you've gained in the past years running an FLS and ways to address some of those issues with patient loss?
Okay, so I wish I had figured this out earlier. It's a big problem. Again, it's sobering that one out of three of our patients stop seeing us for whatever reason. I've been in the medical records of so many patients, and it's as something as simple as there's a phone call documented in the record, and no one treats that differently. So an established patient of ours with rheumatoid arthritis who cancels an appointment is different than an 82-year-old woman in a nursing home who, despite a pre-auth that was for, let's say, a parenteral drug, it's been approved, their out-of-pocket is acceptable, everything's ready to go, they don't show up, and where does that go? So what we're trying to do with our parenterally administered drugs is create lists and work those lists to make sure that we don't lose them, especially the patient who gets denosumab, primarily because of recent concern about patients at high risk on denosumab who stop for whatever reason and then have this fracture cascade. So you have to try to, I mean, really in starting a program and in looking at a database, you have to realize that these things are going to happen, and is there a way that you can try to capture them before it's too late? So it remains to be seen how our pharmacists do. I suspect that they're going to do a better job than maybe what I do, because they can really focus, and they're going to talk in a different way, and patients are going to look at them differently than they look at us. They look at us sometimes as we just want to use our drugs, whereas a pharmacist may be going to give a more balanced view. But very good question.
Wonderful. Thank you so much, Dr. Olenginsky, and thank all of you for joining us today. As I mentioned earlier, this webinar is being taped. It will be posted on Fracture Prevention Central as well as our YouTube channel. I also wanted to mention again that we do have the FLS one-on-one consult service. So if there's questions or other areas you would like to cover, please feel free to go to our site and fill out that form. Once again, thank you all for your time, and we hope you will join us on our next Fracture Prevention Central webinar. Have a great rest of your day.